introduction. Dear guests, dear colleagues, it is my pleasure to speak about how we deal actually in our center in the simplification process of hepatitis care. So as a nurse, I have a role in hepatitis B care, but today I will really focus on hepatitis C care, probably because here we have the most experience in clinical practice, but also in research. First of all, I would like to give you a little bit an update. What do we understand for interprofessional collaboration? So it is that it is a teamwork. We provide care for our patients, that we can optimize their outcomes. And we have to be aware that different professionals are working together. And this is not really simplification, because if we want to simplify the process, it has to be quite clear what roles are of those who are involved in taking care. We have some tasks that can be shared so that we have not double processes in parallel. We have to be quite clear who is doing what with our patients, and what a strategy is also for interprofessional collaboration, or a core element, is patient involvement. And this is really what my heart is beating for. So we have done a lot of research here in Switzerland also with patient involvement, and I would like to give a little bit also a voice to our patients. So when I have prepared this talk, I have asked a photographer if he can give me a picture about simplification, and he gave me this one. So I think for all of you, it's clear, where are we? We are in Paris. It's the Paris by night, the Eiffel Tower. So I really had to think about, and I saw the connection. Simplification means reducing, make it simple in reducing our steps, but that we can really simplify, we have to think first in this Eiffel Tower, because we have to be well aware what are we doing, why we are doing our things, who is involved, who can have which task, and how to perform best practice. So I would say our advantage in St. Gallen was that we had a team who is thinking interprofessionally, but all of us have a huge knowledge and outstanding experience in taking care for this patient group. So it was possible to simplify, to reduce the pathway or the patient journey when we take care. So I will give you a little bit an insight, and this is really now a practical insight. So we have heard today the macro level, world, WHO, Australia, national, international initiatives. Many of our team members had been involved in such initiatives, but I will focus today on the meso level. How did we simplify the procedure in our hospital, in a tertiary hospital in which we provide specialist care? So, and what is the interaction between the team members? And then I would really like to focus a little bit more on the micro level. How do we interact with our patients? So this is, I think, a very well-known HCV care cascade we have done for years. Also, when we started with the DAAs, so you can see we had a lot of appointments, especially we had this referral from primary care to secondary, tertiary care. So yes, we are a specialist center. We have the same experience as you have in Aarau. So we have a lot of referrals from GPs to the tertiary center. I'm happy because I really like to work with patients undergoing HCV treatment. But what we have changed is we have a hepatologist who sees in a short consultation these patients who were referred. Sometimes we have to update some diagnostics, but then closely they hand over these patients to a nurse specialist. She is doing all work with the patients, treatment preparation, ordering the medication, supporting under treatment, and to plan and coordinate post-treatment. And then we have at the end, again, the hepatologist. You have a look on the patient, and we give back the patient to the GP or where he came from. So we have now a nurse-led model of hepatitis C care, especially during treatment and post-treatment. And here I have taken the recommendation from the Australian group. So this means that we have qualified, experienced nurses in the clinical management, and they closely collaborate with the medical specialists. They have proven cost effectiveness, but what we really liked on this model is that the nurses are very close with patients. They try to establish a good relationship, and so we think that we can target different needs as a teamwork. A little bit a pity is that the financing and law system in Switzerland is hindering these nurse-led models of care, but I'm really happy that we can do it as well. So we are a little bit in a gray zone, I have to say. And how does it look like now? This is the nurse-led model of hepatitis C treatment care. You can see these 5 visits. That's individually based. We don't have to do all the 5 visits. But what we always are doing is visit 1, it's face-to-face. We have the patient in front of us, we go in a discussion, we are doing a comprehensive assessment. It's also then followed by a treatment choice and treatment preparation and education. Then treatment will be organized. We have it not in our department as it is too expensive, but we have a close collaboration with a pharmacy who can also send the medication per mail. This is really something what we really appreciate. And what you can see now is if we have a long time between visit 1 and treatment start, probably we go for a phone call. We have at least 1 phone call during treatment, and we have 1 phone call at the end of treatment. Patients have not to come to our clinics, but we like to stay in contact with them. If patients would like to come, of course, they can come and visit us, but most of the time we can excellently run it remotely. And visit 5, it's with the nurses as well. We need the patients there as we have to go for the blood test. So what I said, what is really crucial is this micro level, how we are working with the patients. And we have done many research, especially qualitative research about the experiences of patients. And we have disseminated these research results, and our nurses are prepared to face questions from patients. It can't be me. We all know the uncertainty about transmission. Many people want to discuss and rediscuss this issue. Then, of course, the barriers and facilitators for treatment, starting and being under treatment, and about patient education, that they really know what they are asked to do. A lot of work we are doing in coordination. This is really now, again, interprofessional teamwork, but also external from the hospital. We have many patients. They have also a psychiatrist, a legal advisor, a general practitioner, are in an opioid agonist, in a daily observation treatment. So we have to discuss with these institutions that we start treatment, who takes the responsibility, and so on. And this really works very, very well. There's no issue to work with nurses in coordinating this care. So when I think that the easiest time for us is now with these DAAs, well tolerable, easy, short treatment. I think the treatment time is today really like day and night to the earlier times with interferon. So we have not so much patients with questions, but we give them all phone numbers and addresses. They can reach one of our team members the whole week and 24 hours a day. 4 questions: what should I do if I have lost my medication, if I had an accident and I have to take co-medication, etc. Then end of treatment here, I would like to say, and also in the SVR12 control, we often face questions or statements like this. The first one, that was a student who has done a research with patients getting cured after having a long time hepatitis C, and we have seen that they are uncertain because there is no need for follow-up care. So we have to prepare patients for this time, and nurses are excellent positioned to do this. And the second is, so I have done some research in men who have sex with men with HIV and Hep C co-infected, and there we have really seen that when we early talk with them about the possibility of reinfection, that's a crucial step to that they be careful afterwards, after getting cured. So you can see here, we had patients there with 3-4 reinfections, and they were really open to discuss with the nurses how to better prevent in the future. So the treatment phase, but crucially also after treatment, we can already discuss with patients such concerns. So in this regard, make every contact count. We use teachable moments. This is that we address behavior, problematic lifestyle, and we see and explore how the interest in patients' individual concerns are. We often face that people are so motivated to do to change their lifestyle due to the success of HCV treatment. So this is a really good opportunity, but then we really have to talk about. So our nurses are experienced in patient-centered communication, and they have skills for motivational interviewing. And at the end, it always should result in a plan that we have an agreement with the patient how we move on, especially when there is a lifestyle motivation behind. I would like to conclude, interprofessional collaboration is easily possible, but you have really to clarify the tasks in your team, and the processes have to be defined. Specialized nurses are well positioned to take over important work and tasks within, so that we learn with, from, and all about all team members. Thank you.